Could they be young women looking for fertility and requiring surgery? A little older women facing with certain problems and requiring surgery. So we need to see how we are actually reshaping the future of gynecological surgery, and of course, in which robotics actually plays a role. If I ask you, what is surgery? Surgery is actually a kind of manipulation, cutting, doing something to your body, and would even amount to an assault if I do it without consent. If anybody else wields a knife on you, they'll be taken to jail. But the surgeon has that privilege to do it, of course, with your consent. So you must understand that surgery is not an easy task for both the patient as well as for the doctors to do. The earliest information of surgery actually comes from our own civilization of Indus Valley civilization, which has evidence of surgery almost 3000 to 10,000 BC, some kind of documentation. However, the correct documentation of surgery in our society comes from a book called Shushruta Samhita by a surgeon called Shushruta, who used to practice surgery on the banks of river Ganges 6th BC. Now, I feel proud because I have done my college from the same city of Varanasi, from BHU, and that's why I feel very at home with this kind of surgical principles that we're talking about. But from 6th century BC till about 14th or 15th century AD, we somehow lost way. We actually have no documentation as how surgery progressed in this particular time. The earliest we get some documentation is about 13th, 15th century AD. Now we are talking about 6th century BC to AD, so imagine how many years have passed in between. But we come to know about some information where the surgeons in the European area, where in the period of Renaissance, were called as the barber surgeon. Now you'll wonder why they're called the barber surgeon. Well, the fact is that they weren't physicians at all. They were actually the barbers. We have evidence of how they used to perform surgeries, moving from town to town, village to village, and it used to be a kind of crude surgery, more for the spectacle for the audience. The pain would be there, the infection would result, and of course, I don't know whether they recovered or not. So there were three main problems: pain, infection, and of course, how do you make the surgery for women who need it better so that they recover better? So the first problem was addressed by this gentleman called Dr. T.G. Morton. Now he was a dentist who first thought, how can I numb my patients so that I can do the surgery that I want to do for them? And he, with this simple thing called the ether inhaler, performed first surgery with his friend Edward Abbott in Mass General Hospital in Boston. There was a large jaw tumor for this young man, and they gave ether so that the patient became numb, and they performed. And you can see this dome and this picture, how many doctors are looking with skepticism. Will this work? Will this not work? Of course it worked. And that dome today, even now, has the label of ether dome in Mass General. Well, we have come a long way from ether to the modern anesthesia that we have today. You sleep within a minute and get up within a minute. You don't realize anything. Okay? So the next problem was, well, we have numbed the patient, we can delve into the body, but are these patients living? No, they weren't. Because after the surgeon finished the surgery, what set it in? The infection. And that took the toll of patient's life. The second revolution in surgical practice came by the name of Joseph Lister. You must have heard of Listerine. Even now you get the mouthwash by name Listerine, right? This is named after this gentleman. Now he started talking about antisepsis, how we can prevent infection in a surgical field that we are trying to operate. He came with two simple things. One was talking about washing hands. By this time this gentleman was talking, every surgeon knew that yes, I have to wash my hands after doing the surgery. But what they understood now, that washing before the surgery was as important as washing after the surgery, and that saved lives. The second thing that he came up was simple carbolic acid. Cleaning the surface, cleaning the patient before we did the surgery by antisepsis. Now today we use different type of antisepsis, but this is the oldest and the simplest form of antisepsis that can be used. So these two things almost revolutionized the surgery. The patients were numb, infection got controlled, surgeons became bold. Sky was the limit. They could do any surgery. They could do any delve into any part of the body, do any organ surgery, probably even doing transplant, putting one organ to another, and it was all working. What was the next concept? And that time, the concept was bigger the surgeon, bigger the incision. But did it save life? Yes. But did it give quality of life? No. Because any large incision, any open surgery, gave you an average time of 6 to 8 weeks to heal. Prolonged immobilization, you wouldn't be walking around the next day or come to a meeting like this so soon. Pain and agony in this period, and of course, loss of work. And pay we say, but most of our women may be housewives. We don't document them by pay, but the amount of contribution they do to their home, right from the day of surgery, which I was just chatting with somebody and said, even the night before the surgery, she's so instrumental at home. We never call our patients the night before. We always ask them to walk in the morning of the surgery. So that's the kind of quality we want to give. How do we make our surgeries or our things patient-friendly? Then came the era of minimal invasive surgery or minimal access surgery. That means do your surgery by doing minimal harm to the patient. It's called in very colloquial language as keyhole surgeries. It's patient-friendly, better surgical field visibility because we use telescopes, we use magnifications, and we get into your abdomen or your tummy and have a look exactly where we want to operate.